Hi, my name is Jennifer Cooper, and I will be presenting on 3 causes of antepartum bleeding: placental abruption, placenta previa, and vasoprevia. Although all 3 commonly present with vaginal bleeding during pregnancy, they differ significantly in their pathophysiology, risk factors, clinical presentation, diagnostic evaluation, and management. The purpose of this presentation is to compare and contrast these conditions and discuss the key findings that help rule each diagnosis in or out. The chief complaint shared by all 3 conditions is vaginal bleeding during the second half of pregnancy. With placental abruption, patients typically present with abrupt, painful vaginal bleeding. It is important to keep in mind that some bleeding may remain concealed behind the placenta, so visible blood loss does not always reflect severity. Placenta previa classically presents with painless vaginal bleeding. The bleeding is often bright red and may be mild to severe. Vasoprevia typically presents with vaginal bleeding following rupture of membranes. To start, I will briefly define each condition. Placental abruption is the premature separation of a normally implanted placenta from the uterine wall before delivery, which can compromise maternal and fetal blood flow and become life-threatening. Placenta previa occurs when the placenta implants low in the uterus and partially or completely covers the cervical os, which increases the risk of significant bleeding as the cervix changes later in pregnancy. Vasoprevia is a rare but serious condition where unprotected fetal blood vessels run across or near the cervical os. Because these vessels belong to the fetus rather than the mother, rupture can result in rapid fetal blood loss and death if not recognized immediately. Patients with placental abruption commonly report vaginal bleeding accompanied by abdominal pain, uterine contractions, and back pain. The presence of pain is one of the most important distinguishing features. In contrast, patients with placenta previa typically report painless vaginal bleeding and deny abdominal pain, uterine tenderness, or back pain. Patients with vasoprevia are asymptomatic until membrane rupture occurs. Following rupture, they may experience vaginal bleeding, contractions, active labor, and evidence of fetal distress. When comparing these diagnoses, painful bleeding strongly suggests placental abruption. Painless bleeding suggests placenta previa, and bleeding associated with rupture of membranes raises concern for vasoprevia. Here is a list of risk factors for each condition. Although multiparity is shared among all the 3 conditions, hypertension and trauma are more characteristic of placental abruption. Prior uterine surgery is more characteristic of placenta previa, and placental or cord abnormalities are most characteristic of vasoprevia. For your focused physical exam, patients with placental abruption may have vaginal bleeding, tachycardia, hypotension, and signs of fetal distress. A classic finding is a firm, rigid, or tender uterus. With placenta previa, the primary finding is bright red vaginal bleeding. The uterus is typically soft and non-tender, and maternal vital signs are often stable unless bleeding is severe. With vasoprevia, exam may reveal vaginal bleeding following rupture of membranes. Fetal bradycardia or a sinusoidal fetal heart rate tracing are concerning findings because they suggest fetal blood loss. Across all 3 conditions, the exam should be negative for other obvious causes of bleeding, such as cervical lesions, polyps, or vaginal trauma. The most important physical exam distinction is that placental abruption is associated with a painful rigid uterus, whereas placenta previa is typically painless and vasoprevia is characterized by evidence of fetal compromise. Diagnostic evaluation primarily relies on ultrasound imaging. For placental abruption, ultrasound may reveal a retroplacental hematoma. However, definitive diagnosis cannot be made until after delivery by examining the placenta. For placenta previa, transvaginal ultrasound is considered the gold standard. Diagnosis is confirmed when the placenta is visualized covering or lying within 2 centimeters of the internal cervical os. For vasa previa, transvaginal ultrasound with color Doppler is used to identify fetal vessels crossing or lying close to the cervical os. If bleeding is present, an APT test can be used to determine whether the blood is fetal or maternal to aid in diagnosis. Patients with placental abruption require immediate obstetric evaluation and transfer to labor and delivery for hospitalization, continuous monitoring, IV fluids, serial labs, and blood transfusion if needed. Delivery is often required, especially if near-term and term pregnancies, and with timing based on bleeding severity, gestational age, and fetal status. Depending on gestational age, additional interventions may include magnesium sulfate for fetal neuroprotection when preterm delivery is anticipated, corticosteroids to accelerate fetal lung maturity if delivery is expected within 24 to 48 hours, Rh immune globulin for Rh negative patients, and GBS prophylaxis when indicated. After delivery, patients require close postpartum monitoring for ongoing bleeding and counseling regarding recurrence risk and increased surveillance in future pregnancies. For placenta previa, management focuses on monitoring placental location as pregnancy progresses. More than 90% of cases identified early in pregnancy resolve, so serial ultrasound monitoring is important to determine whether the placenta migrates away from the cervical os and whether cesarean delivery is going to be necessary. Patients diagnosed with placenta previa are referred to maternal fetal medicine for ongoing surveillance and delivery planning. If the previa persists, then planned cesarean delivery is generally performed between 36 and 37 weeks. Patient education upon diagnosis includes avoiding activities that may increase bleeding risk and seeking immediate care for contractions or vaginal bleeding. Patients who do experience vaginal bleeding may require hospitalization, IV fluids, corticosteroids to support fetal lung maturity if preterm delivery is anticipated, and close maternal fetal monitoring. Emergent cesarean delivery might be necessary in cases of severe hemorrhage, active labor, or any evidence of fetal compromise. For vasa previa, management focuses on preventing rupture of exposed fetal vessels because rupture can lead to rapid fetal hemorrhage, exsanguination, and fetal death. Patients are referred to maternal fetal medicine for close surveillance and delivery planning. Corticosteroids are often administered between 28 and 32 weeks because these pregnancies frequently require preterm delivery before labor begins. Hospitalization may be considered between 30 and 34 weeks, depending on individual risk factors and the risk of preterm labor or membrane rupture. Planned cesarean delivery is recommended before labor begins or membranes rupture, typically between 34 and 37 weeks, to prevent vessel rupture and fetal blood loss. Patients are educated regarding pelvic rest and the importance of seeking immediate medical attention for vaginal bleeding, rupture of membranes, labor, or signs of fetal distress. Overall, while all three conditions present with vaginal bleeding or may present with vaginal bleeding, placental abruption focuses on stabilization and potential emergent delivery. Placenta previa focuses on surveillance and planned cesarean delivery if the condition persists, and vasa previa focuses on preventing fetal vessel rupture and delivery before labor. And these are my references. Thank you so much for your time and attention to this presentation on these three differential diagnoses.